Good afternoon, everyone. Welcome and thank you for being here with us today. My name is Kathy Wright and I'm chair of C.A.R.P Ottawa's Advocacy Working Group on Long-Term Care. Before starting, just a few housekeeping items for your information. First of all, this webinar is being recorded. All participants have been muted to avoid interference. And please direct all your questions to the chat line feature, which is at the bottom of your screen. And these will be answered immediately following the presentation. And a very brief poll will be put up on the screen following the presentation. We really appreciate your responses so we can improve the way we do things going forward. So a quick intro on our work. Many of you will know that C.A.R.P Ottawa has been working with several of the other C.A.R.P chapters in Ontario and other like-minded organizations to bring about a sea change in the way care is delivered in Ontario's long-term care homes, from a task-based to an emotion-based model of care. We know that there are at least 4 long-term care models in Canada, the US, and elsewhere that already exist and have embraced that kind of emotion-based care in a homing environment, not in an institutional setting. And they have experienced better outcomes both pre and during COVID, including fewer deaths, fewer cases, and enhanced quality of life for the residents, the staff, and the families. We're trying to increase awareness of the benefits of these homes in the hopes that others will follow suit and that we can convince the Ministry of Long-Term Care that it is the right thing to do. The Commission agreed with us and others, but now it is up to all of us to convince the decision makers. We know that there are at least 15 long-term care homes in Ottawa and more in the offing that have already adopted one of these innovative models of care. This is very encouraging, but there's still lots of work to be done. Today's webinar is our third on this subject, and I'm delighted to present our guest speaker to you. Susan Ryan is the Senior Director of the Greenhouse Project. She has a background in nursing and has served elders for 30 years. With international speaking and project management and experience, Susan has been an integral part of the Greenhouse Project for over 10 years. The Greenhouse model has come to be recognized as leaders in creating high quality, cost-effective, and sustainable human-scale alternatives to the traditional long-term care home. And this model can be adapted to single dwelling homes or developed within larger long-term care homes. So without further ado, I will now hand the mic over to you, Susan.
Well, thank you so much, Kathy. Thank you, C.A.R.P. and Marg. It's been a pleasure getting to know you over the last year. And I say very affectionately, it's amazing to me what COVID has done in that it has really created opportunity for us to really address the failed systems, be it in Canada or be it in the US. That has really, I would say, COVID did not cause the cracks in the system, but it certainly exposed how cracked our systems really are, and really have appreciated the work of C.A.R.P and your desire, as you just expressed it so well, Kathy. So I'm going to share my screen so that you will be able to follow along with me in my PowerPoint today, and really want to just kind of start with what I felt was a really wonderful title. And I give credit to you, Marg. I think you were the one that came up with the Greenhouse Project, a Blueprint for Change. And Kathy mentioned in the introduction of myself is that I have a background as a nurse. And I had what I often refer to as my call to action moment when, as a director of nursing, I realized way back in the day when we were tying people up to keep them from falling, that the system was broken way back then. And I didn't quite know what to do except to keep them in home care. And so for years, I did my very best to keep people out of those dreadful institutions and to keep them in home. Fast forward to 2001 and culture change and some of the models that Kathy referenced were coming to fruition. And I thought, I think it's time for us to reform our system. So I went back in with reformation and transformation in mind. It was in 2005, I heard about Greenhouse, and I'll never forget the moment I stepped into a Greenhouse home. And for me, it was my two worlds coming together, long-term care and home care, just beautifully coming together in a picture of what I said has forever changed who I am, what I do, and how I do it. I found the greenhouse model, that blueprint for change, and it is where it'll actually be 14 years. I need to update my bio. 14 years in March of 2022 that I have been with this, with the project, and really on a mission. So let's talk a little bit about the greenhouse model. What I am showing you right now on this slide is a greenhouse home for 12 individuals. This one happens to be located in Colorado. And if you can kind of see, there's a sidewalk in front, there's a paved street where you'll see other homes as well. So it looks very similar to what perhaps some of you might live in as well. So let's unpack it, lest you think that it's all about the physical design, which is important, and I'll talk more about that. But I'd love for us to really think about what makes the greenhouse model the greenhouse model. When we're talking about it, we don't want to just reduce it to its physical environment. As I mentioned, my background as a director of nursing, I can tell you it has been a paradigm shift. It's really deinstitutionalizing everything I learned as a nurse about long-term care. And when I call it a paradigm shift, it is a paradigm shift. It is really deconstructing all those things that I had held dear about long-term care. It's comprehensively changing it. As I said, I showed you a picture of a home because that's what you see and is most familiar when people talk about greenhouse. But it's not just the physical environment, but it is the philosophical shift and the culture that is developed within the physical environment. And last but not least, and boy, don't we know how important an organizational structure is, and workforce, and really thinking about how does the workforce and the organizational structures also need to shift to really comprise what I call a three-legged stool, and that is greenhouse. And last but not least, I think in the culture change work that I've done, there's often a lot of focus on what gets implemented, but with greenhouse, it's not just implementation, but how do we sustain change? We don't want to be the flavor of the day, the flavor of the month, but we really want to think about how do we sustain change over the long haul. So the greenhouse model, I'll never forget in that visit to Tupelo, Mississippi, the first greenhouse homes. And this was the question that they asked those of us that were there for a visit. And they said, what would you need to live life on your own terms? And honestly, initially I thought, well, that's an interesting question. We need to be thinking about what do they need? But what has occurred to me, it's not what do they need versus what do we need. It's what do we all need as humans to be able to continue to live life and not to be reduced to kind of our diagnoses, but to really acknowledge our shared humanity and recognize that some of those things that I need today are likely going to be some of those same things that I need tomorrow. And that is to be really seen, heard, and known as a unique individual. And the things that are important to me, many of those things are things that I'll want to be able to do as I go forward in life. And I would argue it's probably the same for all of you when you think about what brings meaning to your day. What are some of the simple pleasures that bring joy to you in your day? And how will that change or not as you go forward? But bottom line is, I think we all want a little autonomy and control, that self-determination in what we do. We'll talk more about that. So real home, that physical environment, and I think, Kathy, you said homey. We are all kind of seeking those more homey environments. What you're seeing here are three different manifestations of a greenhouse home that would be similar to the surrounding community. So if you look at the top left, that is in Pompano Beach, Florida. There are, what you see are 12 greenhouse homes. The blue in the middle, that's the elevator bank. And so on either side, is a greenhouse home for 12 people on either side of that elevator bank. And so it is the perfect example of, in that community, a high rise would be more significant to that group. That's condo living in Pompano Beach, Florida. If you go to the right, that's a single family home, another community actually in Colorado. And for them, kind of home on the range, I mean, this is a Colorado infused home. And then down at the bottom left is in Birmingham, Alabama, more of a suburban kind of feel. Each floor, it's a 3-story building, and each floor has a greenhouse home, in this case for 10 people. So homes should be similar to the surrounding community. We will embark on some work with our friends, the New Jewish Home in Manhattan. And so when you think about Manhattan, it's not going to be a single family home as the one up on the upper right, but would be more of that vertical building. So when you think about what makes a real home, and not just homey or home-like, but we really want to go as far as we can to create a real home and everything that a real home needs. So smaller is better. My dad is actually one of 11. And so for him, when you think, 10 or 12 people per home, that would be about right for him. So this smaller is better. And when you hear our COVID data, you'll understand why smaller is better from an infection control perspective as well. Private rooms and private baths. Again, I can't help as a nurse, but not kind of put on my infection control or putting on kind of the COVID cap, if you will, and thinking about what about these homes and that physical environment might have contributed to some of the outcomes I'll share with you. The hearth area, and if you look at some of these pictures I have on the right-hand side of your screen, you will see a hearth area. It's kind of that intentional space for community. I love the way, Kathy, you talked about, some of those models that are really emotional-based care, really about relationships. That hearth area is that place and space for community, intentional community to happen, for relationships to happen. So most of our homes have a fireplace in that hearth area, and then on the other side, you would see an open kitchen, and I'll have a better, well, down there at the bottom, you'll see the open kitchen, where you can smell the aromas of the food being cooked during the day. Private rooms, private baths, and how important privacy is at a time such as this. And on the next slide, I'm going to talk more about access to outside. I can't say enough, again, as a nurse and putting the COVID cap on, how important it was to get people outside, what it does to build our immune system, what it does to support better sleep at night, what it does to support mobility. And you can see this gentleman outside his greenhouse home in New Jersey, really getting a little fresh air and sunshine, boosting his vitamin D levels, but just that opportunity to breathe the fresh air. Now, if you're in a vertical building, you may be wondering, well, so what does that mean if you're in a vertical building? Well, each of those floors gives the ability to really feel the fresh air, to be able to see outside. Actually, what you don't see here in this picture are the big pots of gardening that occurs within each of those screened in porches in greenhouse homes that go vertically. Not only do you have it right there off your home, that screened in porch, but you obviously have the opportunity down on the main level, that access to outside. It's just such an important part of that core value of real home. So moving forward, it's not just the physical environment. You could have traditional, beautiful, small homes. So we have to shift our philosophical culture. And that's what we call meaningful life. And that is where we really get into that relationship-based care, really understanding who a person is as an individual. What you're seeing in front of you is a couple that happen to be celebrating a milestone anniversary. So deep knowing relationships, the staff that were supporting these elders in their greenhouse homes said, we've got to celebrate. This is during COVID time. So they were able to set up their private patio table where they were able to celebrate their anniversary. this was, I mean, can you think of anything more wonderful? I think about, during COVID time and how I could do it outside my home, but I wasn't going to a restaurant, but how they were able to celebrate that meaningful moment for them. So meaningful life, in order for us to have that shift, we have to really create deep knowing relationships. You can't have a meaningful, individualized life where there's purposeful engagements if you aren't in those deep knowing relationships. I mentioned autonomy and control when I think about what would I need. I want some self-determination. I pretty much want to have what I want, when I want it, and how I want it. I don't want a big full breakfast. My husband's always saying, would you like an omelet? No, I want a cup of coffee and, maybe a little fruit or something, but I'm not a big breakfast person. So it's really about relationships that really help enable a person to live with some autonomy and control, and honoring natural rhythms. I'm not an early bird. And so similarly with our elders, rather than having everybody getting up at a prescribed time because that's when breakfast is served, really honoring those natural rhythms. So they're able to sleep in if that's what they want, or if they get up with the birds, they get up with the birds, and they can have what they want when they want it. And boy, that last bullet, social connectedness, how important and how much more important have we recognized how important it is that as humans, we are wired for social connections, and really having the structure within that physical environment to enable the social connectedness. All of these pictures that I'm showing you here is a collage. We asked for pictures taken during COVID, and these are all pictures that were done during COVID. And I think, you can see right smack in the middle, you'll see this was a gentleman living with dementia who was a farmer, and he really, truly got excited when he heard the tractors outside that were plowing the field. Deep knowing relationships said, hey, let's walk outside and we can take a look at what's happening, and the joy and the purpose that it brought him. You can see there's somebody that's actually cooking. This is actually an elder, a younger elder that's living in a home who's actually participating in some of the cooking. So moving on, last but not least, I can't say enough about workforce, and staff empowerment is that final core value that is so intrinsically important. And I will tell you that it's really, empowerment's a function of leadership. You can't have staff empowerment if you don't have leaders who are willing to share power. So let's unpack that value just a bit. The empowered staff, I think they're called PSWs in Canada. In the States, they're called a certified nursing assistant. So that certified nursing assistant is working as a universal worker. What that means is not only are they providing care, but they're doing the cooking, as you can see. They are doing the cleaning, the laundry. So everything in that real home has been decentralized. So you've got your kitchen, you've got your laundry, housekeeping is all right there. And that universal worker is really able to do all of that. They're working in consistent teams and really making sure that they have a dedicated staff, and really making sure that you can't have deep knowing relationships if you're rotating staff. So that consistency, the same people working in that small house each day to really understand each individual elder and their unique rhythm. So consistency, how important. Shared decision making. How often is it that problems are solved, decisions are made from a top-down approach? I can tell you in my previous paradigm, that institutional paradigm, decisions were made at the top, problems were solved here without really taking into account the stakeholder perspective of those working closest to the elder, and even bringing elders into making the best, finding the best solutions. So it's really about leaders that are willing to share decision making. Let's solve problems together and bring the right people to the table to make decisions. And it's that coaching culture that really occurs within each of this. So what are the results? It really creates a sense of ownership. I love the picture in the top center there where she's actually doing some caulking. So that's somebody that's really taken staff empowerment and really that level of ownership that they're able to kind of pitch in and do what needs to be done. I think the other picture to draw your attention to is the one on the bottom left. Don't worry, I've got this. I'm a Shabazz, which is the workforce title for the empowered team, and your loved ones are being taken care of. This was a sign that, you know, when lockdown occurred, family members are wanting to know, is everything okay? And so they started this little video campaign, and this was one of the pictures they sent us, and I just thought it's so depicted that sense of ownership, that sense of confidence, that sense of empowerment that is a part of that core value. So we've been talking about COVID, and as somebody called it, the C word, and as if it were a bad word. And I would say, yes, it has been a bad word, but yet it has created incredible opportunity. So what did we learn during COVID-19? How did these homes withstand the onslaught of a deadly virus? And interestingly, I happen to have been on a panel presenting in early March 2020, and they asked me, so how do you think the greenhouse homes will do amid the pandemic? Actually, it wasn't even a pandemic at that time with COVID-19. And I made what I later started thinking, that was rather audacious. I said, greenhouse home was made for the moment. I can't think of a better infection control mitigation measure than this model. It's ready for the impact of a deadly virus. So how did we do, and how did that audacious statement hold up? So we began collecting data, and it was actually June of 2020. It was after the CDC and CMS, kind of our federal agencies that have jurisdiction over nursing homes, they created a methodology, and it was in June that they were requiring nursing homes to report COVID cases and COVID mortality rates. And so we worked with a COVID research advisor to help us create that methodology so we could compare ourselves using the same methodology with our traditional counterparts. So what you see in blue is what the data we're showing for our traditional nursing homes. And we're looking at COVID cases per 1,000 nursing home residents. So in blue is traditional, green is greenhouse. So looking at data, and that first swath of data was looking from January 1st through May 31st, and then we went monthly after that through the end of the year. So this is kind of what we saw when we compared the national data for traditional homes against greenhouse. You can see on the left-hand side, that's COVID cases. We are less than half of COVID cases in greenhouse homes when compared to their traditional counterparts. When you look at their mortality rates, you can see that we're less than a third of what really was occurring for COVID mortality rates. So moving on, you can see a little bit month by month what that looked like. And I wanted you to be able to see the surges. And so breaking it down month by month, what we're looking at, these are COVID cases per 1,000 nursing home residents. You can see the impact. This takes you through March 2021. So you can see the impact of the vaccine on COVID cases and how they went down both in traditional as well as greenhouse. But with every single month, even amid surges, you can see that greenhouse homes performed far better than their traditional counterparts. If you drill down a little bit further, you will take a look at mortality rates, and you can see again, month by month, you can see, I mean, there were some months where there were no mortality rates whatsoever. So once again, everything that I shared with you at the beginning relative to this model has withstood the onslaught of this deadly virus. And even if there was a COVID case, I think, and I'll talk a little bit more about the specifics of the research, that they were far better able to have that person recover and not have it obviously end in mortality. So let's talk a little bit about our research that was done. And what I really appreciated about our researchers is that they really took a look at the research that was done prior to this study, and they discovered that location had everything to do with it, that where we saw community spread, that's where nursing homes were becoming impacted. Where staff lived in that geography, it was likely as they were going in and out of their communities, they were potentially bringing it back into their community. We heard about asymptomatic transmission. And so it was important in the research that was done on the data we were collecting to really go deeply and look at location, that we really wanted to take a look at where a greenhouse home was located. And we also wanted to, research was showing us that size mattered and that the smaller size model seemed to be performing better, smaller nursing homes. So we said, all right, let's take a look at nursing homes less than 50 beds, traditional homes, and nursing homes greater than 50 beds. And then let's see, how did greenhouse homes perform? So looking at both geography, where's that greenhouse home located? And let's take a look at traditional homes in that same geographical location, less than 50 and homes greater than 50. So here's the data. Traditional homes with less than 50, they had twice the amount of cases that greenhouse homes did. But again, where size matters, look at greater than 50 beds, 9 times the rate of COVID cases. So obviously, just in that same geography, how much better the homes performed. In addition to that, I think this is really striking and a bit surprising, that you might find this as surprising as I did. So when we took a look at the mortality rate, and we drilled down and looked at the per 100 positive cases, how many resulted in death. And you can see in greenhouse homes, kind of negligible, kind of 0.01. But in traditional homes, less than 50, again, that's the smaller traditional setting, per 100 positive cases, half of them were resulting in death. And traditional homes greater than 50 beds, 30 of those 100 positive cases resulted in death. So this was one of those situations where we had a conversation with our researcher. What do you make of that? I mean, it seemed to me if smaller is better, what was it about the smaller traditional nursing homes that half of them, 50% of them were 100 positive cases were resulting in death? And they really seemed to feel that they, in those smaller homes, they didn't have some of the same staffing structures or infrastructure that would have supported them. So when they had cases, they weren't as adept with all those layers of infrastructure that some of the larger homes had. Infection preventionists, they mentioned, and some of the other layers of staffing support, or even the ability to do more cohorting and such in a larger place versus the smaller place. So for me, it was a bit surprising. Here were their conclusions, though. That non-traditional homes, that being the greenhouse homes that were studied, that they were beneficial beyond just their small size. And, really thinking about the private bedrooms and the private baths and what that meant, the limited ancillary staff. So when you go back to that empowered workforce, the consistent staff and fewer people that were coming in and out, when you think about there weren't dietary carts coming in and out, there weren't laundry carts coming in and out, or the personnel pushing those carts in and out. Fewer admissions. What I didn't show you was a slide on occupancy. Occupancy in greenhouse homes remained rather steady compared to their traditional counterparts. And so there weren't admissions coming and going. There weren't hospitalizations that were occurring, where they'd bring them back and risk infection. The other thing, that second bullet, COVID-19 mortality may be less due to the psychosocial factors. I had a bullet on a previous slide that talked about how important social connectedness is. and thinking about some of those psychosocial factors, the consistent staffing. I had some staff in greenhouse homes say, we became surrogate family members. But here's the deal, we already were in such close knowing relationships with them that, you know, we'd already been like their family. But during lockdown, how important it was to really address the whole person and those relational factors and emotional factors that are so important. So here's something that would deserve further study, and I feel it's important to talk about. In greenhouse homes, do they have fewer risk factors? What they didn't do in this study was to really look at acuity levels and look at you know, some of those risk factors that might have contributed to mortality rates. What we do know from other studies, however, is that acuity levels are pretty much the same in greenhouse as they are in traditional nursing homes, but that was not done in this study. Non-traditional homes are more often not for profit and they pay higher wages. We did do a wage study, and in fact, we have shown that to be true, that greenhouse homes, we do pay more than their traditional counterparts. So again, things to consider. Here's some other data that I thought you might like to know. I referenced occupancy just a minute ago. So you can see when we were looking at occupancy in greenhouse homes, May 2021, occupancy in traditional nursing homes at the same time. I think consumers are voting with their feet is how I interpret this, is that 93%, even with a COVID potential dip, we pretty much stayed, greenhouse homes stayed in the 90% or above for occupancy during COVID. Nursing homes, traditional nursing homes, I mean, I think they dipped into the 60s at one point. Look at turnover. So this is, again, when we think about workforce and how important it is to create better jobs, because better jobs will translate to better care. When I think about the opportunity to equip our workers with not just education and knowledge about how to care for people, but life skills, communication skills, and those skills that are, and that life purpose, you know, to be associated with something that's bigger than they alone themselves could do. So turnover rates, you can see what it looks like for RNs in traditional and greenhouse. What I want to point, you might look at the dates for staff turnover, the available data we had, they have not looked at 2020 data for traditional homes. We do an annual look back to look at clinical outcomes and financial outcomes. And we did outcomes, financial outcomes and clinical outcomes for 2020. So we have 2020 pandemic related data. This was pre-pandemic, and this is what their turnover rates were looking at pre-pandemic in traditional. Ours is after the impact of the pandemic. Here's the other thing. There's always this thought, well, it must cost more to operate a greenhouse home. Well, let the numbers speak for themselves. Once again, the data we were able to get for traditional homes was 2019 pre-pandemic operating costs. And they were saying it was about $276 US per patient day. On the greenhouse side during pandemic, 261. So I think those numbers speak well for themselves. So how does evidence inform future design? I would say that outside space, this is a beautiful greenhouse home in Rhode Island. This is that hearth area that I referenced and how important it and cozy it looks here and how important it is to really create that intentional space and place for community. The outdoor space is important, just how important that was during COVID. Front doors and how important a front door is to really creating that sense of real home and an autonomously functioning household. And during COVID time, that was pretty important. Private rooms and the private bath, also important. Really rethinking deliveries into the home. They weren't coming through the front door, there was a back door. And that's how deliveries were being made into the home. How versatile the space was, that even during COVID, that long table that you see in the background of your picture, that was a place where they could actually do some physical distancing and have some meals together. That outside space, they were able to have some meals together, unlike some of our traditional homes were able to do. So a lot of versatility in the space. And cohorting became the buzzword for how COVID was treated in traditional homes. Well, I would say that the small home was, in effect, a cohort. And it really, that limited staffing, the universal worker design, the consistency of that, all had everything to do with it. So with that, I think I managed to end with time for us to have questions. So I'll stop sharing and turn it back over to you, Kathy.
Okay, thank you, Susan. So before we get into the questions, which Marg will organize, we're going to put the poll on the screen, and that will be done by C.A.R.P Central. So if you wouldn't mind while we're doing that, if you could just fill it out, it'll only be up for about a minute. Thank you. So I think maybe while we're doing this, I don't know, Marg, if you want to start the questions.
Yeah, that's fine. So Susan, it was wonderful. And every time I hear you speak, I get reinvigorated again. And I think your homes just look wonderful. And Sheila asked, are there any greenhouse models here in Canada? Do you know of any?
Not yet. We did start work with a group in New Brunswick, but it's very, very, very early in that process right now.
Okay, but you've been doing some seminars across Canada, so I think the word is spreading.
So yes, and to that point, I was saying before we started today's webinar, how much attention we've gotten from Canadian groups, really literally across your country, and particularly with Ontario, but I would say, you know, from east to west, it has definitely been a high level of interest. I will tell you, there has been one large group in Canada that has reached out and would love to, you know, look at what it might look like to work with us going forward. So we're hopeful that, you know, we will be going north of where our borders are at this point.
There was a question or a comment that came up that there's a cooperative owned facility in C.A.R.P, BC. I'm not sure if that's based on any elements of the greenhouse model or not. Probably not from your reaction. Do you know, and so this is just a question on greenhouse homes. Do you know if there's any models out there where they use parts of the greenhouse model and not the total model? And the reason I ask that is that we know with one of the other models, butterfly homes, there are some homes that use parts of the butterfly model, but don't call it a butterfly home. So I'm asking you that question for the greenhouse model.
Yes, I'd say the short answer is absolutely yes. And in fact, you know, going back to my pre-greenhouse days, after I saw greenhouse, we embarked on our own journey within the organization to just kind of embrace pieces of what we saw. The greenhouse model is a trademarked model. And so working with us, you get the whole education, technical assistance, working with your architects and designers to working through the regulatory process. So that's the soup to nuts package. That means you've worked with greenhouse. But you know, similar to my experience before, we definitely know that there are groups that will kind of pick and choose, and then they're just not the trademarked greenhouse home.
Right, and so Sabina had a question as we went along, but I noticed you answered it in one of your slides, and you talked about operating costs of a traditional home being around 276 per patient, whereas greenhouse model for operating costs was 261. And I guess my question, and obviously it's a few dollars less, my question would be, when you start up the greenhouse model, there's obviously costs, and does it take a couple of years then to come down to this comparison that you showed on your slide?
So the development cost, and this is where working with us, we really try to help you control your footprint. The majority of greenhouse homes are not-for-profit, as one of my slides indicated. We're probably about 88% not-for-profit, and so they have used philanthropy. Oftentimes, they've used tax-exempt bonds to finance it. They have used new market tax credits, which is a financing mechanism we have here in the States, and conventional bank financing. So that's how most of the homes have been financed to get those development costs. And depending on where you're building and whether you're going vertically, what your square footage is, the cost will vary anywhere between about $1 million per home and up to, if you're building in Manhattan or some of the more urban areas and you're going vertically where you've got steel construction and elevators and all that sort of thing, then it would be far more 3-4 million, depending on where you're building. And then operating costs,
Right.
To talk a little bit about that, it really is making sure you're doing the cost shifting. So we have more time on the direct care staff. So in the case of Canada, more on the PSW time, but less on, there's no dietary aides, there aren't housekeeping aides or laundry aides, because that's embedded in what that person is doing. Administrative time and some of the mid-level managers, we really believed if we can put more of our hours and wages into our direct care staff, nurses, and the direct care workers, and eliminate some of those middle layers, we can achieve, it's the cost shifting and the cost savings that we can do there. We believe we can, we have evidence to show that we can control our food costs better. When you know what people want to eat and what they like to eat, you're not making one thing, one size fits all for everybody, but instead you're customizing. You're better able to even use some of the leftovers, what we had last night for dinner that's still fresh, and it's what somebody wants that night for dinner because I just really liked it last night and I'd like it tonight. So you really control waste and different things like that. Early detection translates to saving some cost on some of your medical supplies. So in those relationships with nurses and the direct care staff, if you're able to intervene earlier, you prevent the hospitalizations. We have research that shows that hospitalizations are less in greenhouse homes than their traditional counterparts. Because again, that early detection, if we can address something before it becomes something you need to get them into the emergency room, far better. Hope that answered.
Okay,
Yeah,
so perhaps while Marg is trying to get back on, Susan, what about, you talked a bit about leadership. There's a question here from Susan Paul. How did you convince people to change? What approaches did you use?
It's a great question. And we use a construct in our education that we call beliefs, behaviors, and systems. And it's embedded into all of our education materials. And so within that, we really help to uncover and identify our beliefs that have limited us in being able to embrace a new way of caring. And oftentimes the way we see people that are aging as declining, as less than, as devalued, and sometimes it's unconscious, but it's really uncovering some of those roots and beliefs and mindsets that have limited us and where we're going. Culture change is not just about saying these are the new behaviors without first uncovering and identifying those mindsets and beliefs. And then we can better, determine what are those behaviors we'll want to see. And then last but not least, and what are the systems that we need to have in place to support the new behaviors that are there. We use Kotter's change theory, if you know the 8 steps of change with John Kotter. That kind of informs our work with organizations. And so we really try to bring to the forefront, it really is all about leaders and really making sure that they have fully embraced the vision, the why, they've created that sense of urgency and the climate for change. And then we really work hard to making sure that it's not just a check the box education, but it is an ongoing learning growth process that the entire organization and culture will embrace so that sustainability can be achieved. And then last, but I didn't really talk much about how will we hold ourselves accountable to that sustainability. We have an annual model fidelity tool that measures how well are we living those core values. It is a multi-stakeholder survey that is given to the direct care staff, to leaders, to nurses, so that we're really taking a look at from everyone's perspective. It's putting the mirror up and saying, are we living it? And then the organizational outcomes that I talked about, the clinical and financial outcomes that we look at each year, just to make sure that we're learning from each other. There's this whole collective wisdom of our community of thought leaders, those that are doing it. So we kind of benefit from learning from each other.
Thank you. So Mark, just while you were in and out, we addressed the question, how did you convince people to change and what approaches did you use? And you might have figured that out from when you joined back on.
I did. Thank you. My internet's unstable. So it brought to mind your answer, which I heard most of it, was about the education and training that they need initially for greenhouse staff, because there's been a question about that. And I know you've been talking about ongoing education, but initially you have a full training program, do you not, for staff?
Absolutely. And we really do a train the trainer model so that we really bring educators, identified educators within the organization to a greenhouse location. So they're able, I call it the learning laboratory, where they're able to get into greenhouse homes, have conversations, informal conversations with the elders in the home, with the staff that are there to support them, nurses and the direct care staff and such. We have the leader of that greenhouse organization speak to the educators, and then we unpack the curriculum. And this is the curriculum you'll take back to your communities. We have project coaches and education coaches that then help you better work with that educator to create an education plan, and then to work with others on the leadership team to really create the action plan and implementation plan to go forward. So there's incredible intention in how we apply knowledge and really create cultures where that education can live, grow, and thrive.
And it's interesting too, because there's a question here from Gwen, and it's an appropriate question in terms of how do you deal with residents of different levels of care? And certainly we saw your pictures where people are active, they're taking part in their daily activities at the greenhouse. But do you have residents that aren't able to do some of the things that we saw in the pictures? Like, what would you say about the residents who need a lot more care than what we saw in the pictures you showed us?
It's really interesting, and we have a principle with our dementia education. It's called the power of normal. And what happens, the impact of normalizing our environments and our programs, and really even our beliefs. And really we just, another principle is focus on retained abilities. And so when you embrace some of those philosophical tenets and operationalize that, it's amazing what people that in a traditional environment looked unable, uninterested, or their acuity levels were too high. What happens when you put them in a smaller environment where you really try to tap into who that person is, what their retained abilities might be, what they're able to accomplish. I could tell you story after story of people that were not able to feed themselves in the traditional building, where when they moved into their greenhouse home, they sat around that one table and there was something so familiarizing about that table. They picked up their fork and they were able to feed themselves. Similarly, because the distance between their bedroom to the table is a navigable distance, rather than taking a wheelchair down the long hallway to the dining room, with support, assistance, and part of our philosophy, once again, is mobility is important. So what can we do to really help them achieve the mobility essential to be able to traverse to the dining room table? And even, if maybe they can, but we have ceiling lifts in each of the rooms where we're able to transfer them to their wheelchair and get them out, get them outside, get them doing things where there is that sense of normalcy, where their acuity levels have been high. And just real quickly to tell you, in Boston, there are 2 of their 10 greenhouse homes that are dedicated for people living with Lou Gehrig's disease. And 4 of those individuals are on ventilators. And I can tell you that philosophically, what they've been able to do, one of them wrote, they have technology that supports them. One has written a play. There are some of those individuals, not those on ventilators, but living with Lou Gehrig's disease, somebody living with multiple sclerosis. They actually went skydiving. It was the dream of hers to be able to do that. You know, she can feed herself, but she's challenged me to go with her the next time she goes up. I'm not so sure I've got the appetite for it. But my point is that where we have limited our thinking about what's possible, this model is about helping us to uncover some of our limiting mindsets. Myself being one of those, I was steeped in keeping people safe and having that preponderance, safety first, and really just kind of rethinking about the dignity of risk, which is another one of our principles. And what can we do to really embrace not just a new way of caring, but a new way of enabling life and empowerment. And I'm going to just do a real quick shameless plug for our podcast called Elevate Elder Care. And it's on Apple, Spotify, or Stitcher, wherever you find your podcast. I bring it up because today's episode that went live is an interview I did with a nurse, an administrator, and a Shabazz, or the direct care staff, that empowered worker, in a greenhouse home that opened during the pandemic. And in that interview, you hear really from the people who are doing it day in, day out. And you can hear about what they do, how they do it, why they do it, and kind of the result of some of the education that has been operationalized. And I can be the mouthpiece up to a certain point, but I just think it's time that we listen and learn from the people who are doing it. And my episodes in December, I'm talking to elders, not elders in greenhouse homes, but hearing the voice of elders, a 94-year-old Holocaust survivor, and an 88-year-old woman who was sharecropper's daughter, an African-American woman who became U.S. Surgeon General, and that's Dr. Joycelyn Elders. And so those are, let's listen, let's learn, let's talk to the people who are doing it, and let's find solutions together.
I have just 2 quick questions before we have to terminate shortly. Maybe they're short answers. Are community colleges involved in any of your education for your staff?
Great question. And just before the pandemic, and we are still, I had a conversation yesterday with somebody that where we've got certified nursing assistant programs in community colleges. We've talked about how do we get kind of that person-directed focus embedded into their curriculum, and how do we work alongside with them? How do we really bring some of the tenets of the greenhouse model into those conversations? Looking beyond just that direct care worker, but really thinking about nursing schools. There are some that they have had some of their internships done in greenhouse communities, but those are very, very few and far between. But I think it's something, as we're thinking about our education plan going forward, it's something that's kind of on our list of trying to think about how do we really start getting into those universities to really have them thinking and equipping kind of a new generation of leaders to be able to embrace new ways of doing things.
And there was a question, and I know it's different in the States than it is in Canada, but do residents pay the full monthly costs? So there must be the American, how does it work in your system?
So we have 3 payer systems. The first is private pay, where the resident would be paying the full freight. But we do have a Medicaid, which is government funded. It is a federal and state program. It varies state by state what that reimbursement rate would be. And then the last is for short-term rehabilitation, and that's Medicare, and that is a federal program, but it is short-term for that. So we did in fact, the people that you'll hear if you listen to the podcast, they're about 70% Medicaid funded. So it's just you get an idea. And then I want to say they've got a couple homes that are dedicated to short-term rehab, which Medicare would be the payer for that. So yeah, it's definitely finding the right payer mix to make it work. Some states reimburse better than other states. Arkansas, in which this place is located, there is a bump in the Medicaid rate if you're embracing this small house model. So in that particular state, they are incentivizing through a bump in their Medicaid rate if you're doing the innovation of greenhouse.
It seems that we're at the bewitching hour, and we had agreed that we would end this with just a few minutes to spare, so that I could really thank you, Susan, on behalf of all of us who have been listening to a most informative session. You know, timing is everything. And as you said, COVID-19 showed the deficiencies in the systems here in Canada and elsewhere in the world. And that's why we are at C.A.R.P are trying to make a push now for emotion-based models of care. So thank you for all the work that you do to empower lives, because that is what you are doing. You are empowering us to move forward, to make it better for us here in Canada. I wish we could clone you. You could come and lead us through this revolution, and this revolutionary that we need, this whole system change that we need here in Ontario, and particularly in Canada for sure.
Well,
so thank you so much again, Susan.
We stand at the ready to support your efforts. So let's keep the dialogue going, and we'll do what we can for sure.
Right. And I'd also like to thank everyone who joined in on our webinar. And we really appreciate you taking an interest in what we're trying to do. We encourage you to look at our website, Change Long-Term Care Now, where you can get more information. And there'll be more webinars in the future. So stay tuned. And Kathy, is there anything else that you would like to add at this point? I'm seeing a shake of the head, and so I will bid everybody a good afternoon and wish you a very good day. Thank you so much again, everybody.
Bye-bye. Thank you.